Welcome to part 2 of the radiographic image analysis of the elbow. Radiographic image analysis guidelines for the lateral projection of the elbow state that the anterior, posterior, and supinator fat pads should be demonstrated. The elbow should be flexed at a 90 degrees. In the humerus, the distal surfaces of the capitulum and medial trochlea are nearly aligned. The anterior surfaces of the radial head and the coronoid process are aligned. In the forearm, the elbow joint should be demonstrated as open. The anterior surfaces of the capitulum and medial trochlea are near aligned. The proximal surfaces of the radial head and the coronoid process are aligned. The radial tuberosity should not be demonstrated in profile. The elbow joint is demonstrated at the center of the exposure field, and the elbow joint 1/4 of the proximal forearm and distal humerus and the lateral soft tissue are all included within the exposure field. I have included those guidelines within our presentation. So let's talk about some malpositioning errors that commonly occur during the lateral forearm or lateral elbow projection. In the first image, this is a demonstration of proximal humerus elevation. That is where the proximal humerus is positioned higher than the distal humerus. And so that arm is not in the same plane as the proximal humerus. We need to elevate it so it's all in the same plane. When this occurs, the distal surface of the capitulum is demonstrated too far distal to the distal surface of the medial trochlea, and the radial head is placed too far posteriorly to the coronoid process. In distal humerus depression, that is where the patient's elbow is actually positioned a little higher than your proximal humerus. And when that occurs, the distal capitulum is demonstrated too far proximal to the distal medial trochlea, and the radial head is positioned too far anteriorly to the coronoid process. So now let's look at what happens or what occurs when the distal forearm is either depressed inferiorly to the elbow or elevated above the elbow. In depression, this occurs when the distal forearm is positioned too close to the IR. The projection will demonstrate the capitulum anterior to the medial trochlea, and the radial head will distally to the coronoid process. In elevation, where the distal forearm is elevated off of the IR, the projection shows that the capitulum is demonstrated posteriorly to the medial trochlea and the radial head proximal to the coronoid process. So moving forward, let's talk about the wrist rotation if we don't have the wrist in a true lateral projection. We know that when performed this appropriately, the lateral wrist projection will situate the radial tuberosity on the medial aspect of the radius, where it is superimposed by the radius and is not demonstrated in profile. Now, with external wrist rotation, that allows for the it rotates the radial tuberosity toward the anterior arm surface, where it is partially demonstrated in profile. In internal wrist rotation, this rotates the radial tuberosity to the posterior arm surface, demonstrating it in full or partial profile posteriorly. So let's take a look at our first practice analysis. In this first practice analysis, we can see that the relationship of the radial head and coronoid process are not positioned appropriately. The radial head here is positioned too far posterior to the coronoid process. The capitulum is positioned too far distally to the medial trochlea. This allows for us to know that the proximal humerus was elevated, meaning that the distal humerus was not on the same plane as the proximal. We need to depress the proximal humerus until those humeral epicondyles are superimposed in order to correct this imaging error. In our next practice analysis, again, we're going to look at the relationship between the radial head and the coronoid process. This time, this radial head is positioned too far anteriorly to the coronoid process. The capitulum is demonstrated too far proximally to the medial trochlea. This means that the proximal humerus was depressed, that the elbow is sitting higher than the proximal humerus. In order to correct this imaging or positioning error, we need to elevate that proximal humerus until the humeral epicondyles are superimposed. Again, we're going to start with this lateral elbow analysis with looking at the relationship of the radial head and capitulum. In this situation, the radial head is positioned too far distal to the coronoid process, and the capitulum is demonstrated too far anteriorly to the medial trochlea. This means that that distal forearm was in contact with the IR and depressed down, allowing for the elbow to be situated higher than the distal forearm. When this occurs, we need to elevate the distal forearm until the humeral epicondyles are superimposed to correct this imaging or positioning error. And for our last elbow practice analysis, again, we're going to look at that relationship between that radial head and the coronoid process. And in this instance, the radial head is positioned too far proximal to the coronoid process, and the capitulum is positioned too far posteriorly to the medial trochlea. This means that the distal forearm was elevated, where the hand was up some, and the elbow was lower than the wrist. They're not all in the same plane. In order to correct this imaging error, or this positioning error, we need to depress the distal forearm until the humeral epicondyles are superimposed. This concludes the image analysis on the elbow. If there are any questions, please feel free to reach out. Thank you for participating in this presentation.